This lecture covers the topics of evidence-based practice and information retrieval. We can see in the core content outline that this topic is covered in section 2.2, focused on evidence-based patient care and including information retrieval and analysis. If we drill further into the core content outline for this topic, we see that there are many topics related to what we usually call evidence-based medicine, including sources of evidence, grading of the evidence, implementation of the evidence in clinical guidelines, then implementing guidelines as clinical algorithms in information systems, as well as clinical practice. This area also includes information retrieval, even though we search for more information than just evidence for clinical decisions. We search for many different kinds of topics, but we'll cover information retrieval here, including search skills and critical analysis of the biomedical literature. Here are the key topics we'll cover in this lecture. We'll begin with the process of evidence-based medicine, where we formulate an appropriate clinical question to find and apply evidence. We then retrieve studies and critically appraise them based on the clinical question types, with the four major ones being treatment, diagnosis, harm, and prognosis. We'll look at evidence grading schemes. We'll discuss clinical practice guidelines, and then cover the topic of information retrieval or search systems, their content, indexing, retrieval, and evaluation. Here then is an overview of what we'll cover in this lecture. Again, we'll cover the topic of evidence-based medicine and discuss using evidence-based medicine to answer questions about intervention or treatment. Diagnostic statistics are also a part of evidence-based medicine, but those were covered in lecture 2A-1. We'll also talk related to evidence-based medicine about summarizing evidence and implementing evidence in clinical practice guidelines, and then we'll also discuss the topic of information retrieval and analysis. Let's begin by defining evidence-based medicine, or EBM. Most will define EBM as a set of tools and a disciplined approach to informing clinical decision-making. In other words, we apply the best evidence that's available to make clinical decisions. There have been a number of textbooks over the years. Probably the most widely known and most recent are the larger manual and smaller handbook produced by Guyot and colleagues. Evidence-based medicine doesn't ignore clinical experience or the art of medicine, but instead aims to integrate it with the best clinical science. Evidence-based medicine also makes the biomedical literature more clinically applicable and relevant. And when we're discussing evidence-based medicine, we cannot forget the caveat attributed to Carl Sagan that absence of evidence is not evidence of absence. In other words, just because there's no evidence for something doesn't mean that it's not the right thing to do, but that evidence must be explicitly present or not present for us to use it or not. When we are applying EBM, we need to think of the hierarchy of evidence. And this comes from a model that was originally called 4S and then 5S and now 6S that shows us one way of looking at the hierarchy of evidence that we use and apply. The foundation of evidence is the original research that generates the evidence, the randomized controlled trials, the other types of studies that give us the evidence. These are typically original articles that are published in biomedical scientific journals. Sometimes we read about these studies in synopses of these studies. So there are evidence-based journal abstracts that are published that provide a synopsis of the original study. When there are many original studies, we need to synthesize them so that we take into account all of their evidence.
The most common approach to doing this is called a systematic review, where there's a systematic process of gathering and refining the evidence that comes from the original studies. These are called syntheses or systematic reviews, sometimes called evidence reports. And of course, there may be synopses of these as well. The next level up is summaries. Syntheses can be quite long, and in the busy clinical setting, what we really want is a summary of the evidence. And these summaries come from evidence-based textbooks and collections. And ultimately, we want actionable knowledge from systems that we can use, for example, for clinical decision support in the clinical setting. Depending on the level of the hierarchy, the sources of evidence come from different locations. For example, the studies are original journal articles. They're mostly indexed in Medline, which is how we search to find them. Syntheses come from systematic reviews that may be published as journal articles, but also may be part of collections such as the Cochrane Database of Systematic Reviews. Summaries typically come to us in the form of textbooks, compendia, and guidelines. And then finally, systems come to us as guidelines, decision rules, and order sets.
Let's give an overview of the application of evidence-based medicine. No matter what the question we're asking, we follow a series of general steps, and how we implement those steps depend on the type of question. But the steps always include, first, phrasing a clinical question that's pertinent and answerable. This may be the most important part of EBM, even though it doesn't get as much attention as calculating various statistics and so forth. Once we have the clinical question, we identify evidence that enables us to address it, and then we critically appraise that evidence to determine if it applies to a specific patient at hand. We distinguish between background and foreground questions. Background questions are those questions that ask for general knowledge, and these are usually answered with resources like textbooks and classical review articles. Foreground questions are really the questions that we apply the specific techniques of EBM. We usually are asking for knowledge about managing patients with a specific disorder, and this is when we apply the appropriate EBM techniques.
Let's look in more detail at foreground questions. They typically have 3 or 4 essential components. Many of you have heard of the PICO mnemonic, which reminds us of the 3 or 4 components. The first of which is the patient and/or his or her problem. Second is the intervention, whether it's a treatment or a diagnostic test, etc. There may be a comparison intervention, and then there will always be outcomes that we're looking for the question. So for example, an example of a foreground question is, in an elderly patient with congestive heart failure, are beta blockers helpful in reducing morbidity and mortality without excess side effects? There has actually been recent expansion of the PICO mnemonic to PCOTS, where the T and S add the timing of the intervention, such as when in the course of the treatment or the disease, and the setting. Is it in the hospital? Is it in the community? And so forth. Most foreground questions can be placed into one of 4 categories. These categories of questions are very important because they define the most appropriate type of evidence and the various statistics that we use to make decisions about patient care. The first of these categories is intervention, sometimes called treatment or therapy, where we're assessing the benefit of some approach to treatment or prevention of disease. The second category is diagnosis, where we're looking at a test that's diagnosing disease. The third category is harm. What is the etiology or cause of disease? And then the final category is prognosis. What is the outcome of the disease course? Using the category of question, we then seek out the evidence and find studies. And then we critically appraise those studies. And there are three general questions that we ask about any study that we're evaluating. First, are the results valid? Second, are the results important? And then third, can the results be applied to patient care? There are specific sub-questions which within each of these major questions, and the specific sub-questions depend on the type of question as well as the type of study that we retrieve. Let's focus in on using EBM to assess questions about interventions or treatment or therapy. Again, we're looking at questions that concern the benefit of a clinical intervention to treat or prevent disease. We most commonly think of this as drug therapy, but it can be any type of intervention, diet therapy, surgery, alternative medicine, etc. When looking at evidence about interventions, the best evidence comes from a randomized controlled trial, or an RCT, or a meta-analysis of such trials. The key in a randomized controlled trial is that the patients are similar in all regards, with the exception of the intervention that's applied.
When we're asking questions about the effect of interventions or treatments, one of the questions we want to answer is, what is the treatment effect from a given intervention or treatment? The treatment effect is usually measured in terms of risk of an undesired outcome, an event like mortality, recurrence of disease, complications from the disease, and so forth. There are two main categories of treatment effect. There are the relative measures, where we look at the risk relative to the control group. Ideally, if the treatment is effective, there will be less risk for the experimental group than the control group. A second category that we look at for treatment effect is absolute measures. What is the absolute risk for the control and experimental groups? Within the relative measures, there are a number of measures that differ somewhat from each other, but still measure risk relative to control. The most commonly used measure, relative measure in EBM, is relative risk, or sometimes called the risk ratio, where we look at the risk relative to the control. If the risk is less for the experimental group for developing these undesired outcomes, then the relative risk will be less than 1. From the relative risk, we can calculate the relative risk reduction. We'll see that in a moment. There's also the odds ratio, which is the odds of having one of these undesired outcomes or events versus not having it. And again, if the treatment is effective, the odds ratio will be less than 1. There's also the hazard ratio, which again is a measure of relative risk, but it accounts for time and survival. And in the analysis, researchers will align the time from when the experimental trial begins to events that happen. Absolute measures look at the overall population. The absolute risk reduction or risk difference is the absolute difference of risk, again, between the experimental and control groups. From the absolute risk reduction, we'll see we can calculate the number needed to treat, and that is how many people must be treated or have the intervention for one person to benefit. If we work through the examples on these, we can see how they're calculated and get a better understanding of what they mean. When there is a treatment effect, we of course want to know how large it is, and this slide depicts the usual approach that's taken in EBM. We begin by creating a 2x2 table. The rows of the table have the intervention, whether the experimental group or the control group. And the columns have whether or not the patient had the event, that undesirable event that we described in the previous slide. Again, things like death, complication, progression of disease, and so forth. The numbers that we calculate in this table are predicated on the difference being statistically significant, which the paper or report of the research will usually calculate and describe. If the results are not statistically significant, the results from this table and these calculations don't really matter. They must be statistically significant. Once we have the 2x2 table, we can then calculate the experimental event rate, the risk of the event from the experimental intervention, and the control event rate, the risk of the event from the control intervention. So we see that for the experimental event rate, the calculation is the number of people who had the event divided by the total number of people who had that intervention. Likewise, for the control group, the control event rate is how many people in the control group had the event divided by the total who were in the control group. This then lets us calculate relative risk, which is the experimental event rate divided by the control event rate. If the experimental event rate is less than the control rate, the experimental intervention will be effective and the relative risk will be less than 1. From that, we can calculate the relative risk reduction, which is 1 minus the relative risk. We can also calculate the absolute risk reduction. That's the control event rate minus the experimental event rate. And from that, we can calculate the number needed to treat, which is 1 divided by the absolute risk reduction. In addition to knowing the magnitude of the treatment effect, we also want to know its precision. How precise is the estimate from the study of the treatment effect? We need to remember that for a whole population, everyone with a given disease, we can't know the true risk because we're not measuring the entire population. When we do an experiment, we draw a sample of people that hopefully represent the population in general, and they take part in the experiment, in this case, the randomized controlled trial. When we do the study, the RCT, we get a point estimate of the risk, but of course that's just an estimate, and the true result can vary due to chance, bias, or other reasons. Some of the reasons why the sample may diverge from the larger population is that we may have drawn a different sample than is representative from the whole population, or there may even be bias in studies that are not performed properly. We measure this precision of the treatment effect by calculating a confidence interval. The confidence interval tells us that there's a range of values that includes the true value 95% of the time. So when the confidence intervals are non-overlapping, that means the chance of the results being due to chance is less than 5% if we've calculated the 95% confidence interval. Let's look at an example of calculating the treatment effect. We'll look at a study that compared standard versus intensive blood pressure control in the elderly. Some of you probably know this as the famous SPRINT study that looked at elderly patients who had a systolic blood pressure greater than 130 and increased cardiovascular risk, but did not have diabetes. And the question was whether it would be better to aim for a systolic blood pressure target of less than 120, which would be intensive treatment, versus less than 140, which would be standard treatment. The primary outcome in the study was a composite of myocardial infarction, other acute coronary syndromes, stroke, heart failure, or death from cardiovascular causes. The study was actually stopped early after 3.25 years, as it was found that the intensive treatment group had a hazard ratio, so a measure of relative risk of 0.75 with a 95% confidence interval between 0.64 and 0.89. So the study was stopped because the results were statistically significant in favor of more intensive treatment. Let's look at the numbers from the paper and do some calculations of the treatment effect. You might want to look at this slide and the numbers and then stop the lecture and do your calculations and see whether you did them correctly as shown on the next slide. So in order to calculate the treatment effect, we create the standard 2x2 table with the experimental group, in this case intensive treatment of blood pressure, in the first row, and the standard or control group in the second row. We then have columns for the composite cardiovascular outcome of patients having that outcome or not having it, and then we see the totals in the final column. So there were 243 patients in the intensive treatment group who had an adverse cardiovascular outcome, as opposed to 4,435 who did not. In the standard or control group, 319 patients had a cardiovascular outcome and 4,364 did not. So let's answer the following questions for standard versus intensive blood pressure control in these elderly patients at increased cardiovascular risk but not having diabetes. So what is the relative risk reduction of intensive treatment, and how many people must be treated to reduce one cardiovascular outcome? Let's look at the results of the calculations of the treatment effect. We first calculate the experimental event rate and control event rate, which we see are 0.052 and 0.068 respectively, or 5.2% versus 6.8%. This gives us a relative risk of 0.76 or 76%. So those in the intensive treatment group had about a 3/4 likelihood of developing one of the adverse cardiovascular outcomes compared to the control group. This is slightly different, but close to the hazard ratio that was reported in the paper. We can then calculate the relative risk reduction from the relative risk, which was 24%. We can also calculate the absolute risk reduction, the control event rate minus the experimental event rate, which is 1.6%, meaning that the patients in the experimental group had an absolute risk reduction of 1.6%. We can calculate the number needed to treat, which is 1 over the absolute risk reduction, and is calculated to be 62, meaning that 62 people must be treated to reduce one cardiovascular outcome.
For many clinical questions, there is not a single study that provides all the evidence. Therefore, we need some way of summarizing multiple studies. This used to be done with review articles where some expert would provide a narrative review of all the known evidence. In more recent decades, however, there has been a growing trend towards the use of systematic reviews, which bring together all the evidence on a treatment or a test or really any type of clinical question together in a more systematic and comprehensive approach. Systematic reviews are sometimes called evidence reports. So going back to the 6S model, there are syntheses that bring the primary data, the primary research results together, while summaries make it available to users in a highly digested and summarized form. If there are multiple similar studies available, then we may use a technique called meta-analysis, where we combine the results of these multiple similar studies as if they were a single study. There are other situations, however, where the studies are too heterogeneous in terms of patient characteristics, settings, or other factors, and we cannot perform a meta-analysis. Therefore, we still have a systematic review that summarizes all the evidence, but we can't combine it all as if it were a single study, which we can do with meta-analysis. When a meta-analysis is done, there are summary measures that are employed. If we're looking at events, such as the type that we looked at when we were looking at questions of treatment, we use the odds ratio. There may, however, be studies that have continuous variables instead of discrete variables, and in those situations we use either the mean difference or the standardized mean difference. The production of systematic reviews is almost synonymous with a group called the Cochrane Collaboration, which is an international collaboration whose mission is to produce systematic reviews of medical interventions. Most of the reviews from the Cochrane Collaboration include meta-analysis, and the Cochrane Collaboration logo itself tries to give a picture of what meta-analysis is potentially capable of doing. If we look into the inner circle, we see that there are multiple horizontal lines, each of which represent a single randomized controlled trial, and the span of the line indicates the confidence interval. The study questions in most Cochrane reviews are configured so that the vertical line represents either odds ratio equals 1 or weighted mean difference equals 0, and anything to the left of the line is a treatment benefit. And if the horizontal line representing the confidence interval doesn't touch the vertical line, then the results are statistically significant. The particular question that is looked at in the logo is the benefit of administering steroids in preterm labor to the fetus. This was a question that had a number of small studies that were either inconclusive or not statistically significant, but when the results were all combined into a single meta-analysis, there was clear benefit that was statistically significant for administering steroids in preterm labor.
Let's turn our attention to clinical practice guidelines. First, let's define them, and the most widely accepted definitions come from the Institute of Medicine, initially back in 1990 and in a more recent updated report. Clinical practice guidelines are systematically developed statements to assist the practitioner and patient decisions about appropriate health care for specific clinical circumstances. Clinical practice guidelines usually aim to normalize the care that is delivered. They are represented in a variety of ways. They may consist of a series of steps for providing clinical care, or represented as text with tables or algorithms. How do we construct clinical practice guidelines? There are a series of steps to create evidence-based clinical practice guidelines. We first gather evidence for the important outcomes. We grade the quality of that evidence. We ascertain the balance of benefits and harms for various actions in the clinical practice guidelines. We determine the strength of recommendation, and then we implement and evaluate them. It's important for each step in a clinical practice guideline to grade the level of evidence. The grading of evidence is one of the core content outline elements, but it's also important from the standpoint of what is the evidence to support the recommendations in a guideline. There have been many evidence grading schemes over the years, but one that is emerging as a standard is the so-called GRADE system, which stands for Grading of Recommendations, Assessment, Development, and Evaluation. The GRADE Working Group maintains a website that describes the latest approaches being used under this grading framework. In essence, the GRADE approach emanates from the table shown here. There are two main study designs from which evidence is based. One is the randomized controlled trial, which initially has a high quality of evidence, and an observational study which has a lower quality of evidence. There are then attributes of the study that will raise or lower the quality of evidence by 1 or 2 levels. For example, if there's serious risk of bias, the quality of evidence will be downgraded 1 level, or if it's very serious, then 2 levels. There might be inconsistency in the results of studies going into the evidence, which would downgrade its quality. Also lowering the quality of evidence might be indirectness in terms of whether the study questions directly or indirectly address the clinical question at hand. Quality can also be lowered by imprecision or wide confidence intervals, as well as likelihood of publication bias. There are some attributes that will increase the quality of the evidence. For example, when there is a large treatment effect or evidence of a dose response for the intervention, the quality of evidence may also be increased when all plausible confounding is accounted for or would suggest a spurious effect when the results actually show no effect. So, for example, a randomized controlled trial that has a serious risk of bias would start as high quality of evidence and then be downgraded to moderate quality of evidence. On the other hand, if it had a large effect, the quality of evidence may go back up from moderate to high. Another evidence grading scheme attempts to account for the direction of the evidence, and this is, of course, important in areas like preventive services. So there is the U.S. Preventive Services Task Force grading scheme. The U.S. Preventive Services Task Force is an entity that makes recommendations for preventive services, such as screening. It's funded by the U.S. government, but the task force members are non-governmental. These task force members look at the evidence and assign the grades listed here. The strongest grades in terms of the direction of the evidence, the recommendation, having good evidence to support it, are A, and then to a lesser extent B. A grade C means the evidence could still be strong, but the benefits from the intervention are small. And grade D is where the evidence could also be strong, but the net benefits are either 0 or negative, so something might be detrimental to do. When the evidence is unclear, that's when the recommendation gets a grade of I, and more information about these recommendations can be viewed at the Preventive Services Task Force at the URL listed here.
There are a number of well-known limitations of clinical practice guidelines, and these become important as we try to implement them in clinical information systems. One limitation is that guidelines may not apply in complex patients. For example, one analysis looked at guidelines for 15 common diseases that are seen in elderly patients, and for those who have comorbid diseases, there may be undesirable side effects, and this may even have implications for various pay-for-performance schemes that we try to guide physician behavior with. Another challenge with guidelines is that they may be complete or inaccurate. One analysis looked at 11 guidelines for oral medications in type 2 diabetes, finding that several of them varied from the known best evidence, with those based on evidence-based processes being judged of higher quality. Guidelines are not always precise in their logic, and they can be difficult to implement in EHRs, particularly when we tie them to clinical decision support rules. And if they are imprecise, it may be difficult to pull data from specific elements and use that in the guidelines. And then finally, the problem of conflict of interest. For one analysis of 17 cardiology guidelines, it was found that 56% of the authors had a reported conflict of interest, most commonly being either a consultant or a member of an advisory board. Now, having a conflict of interest doesn't necessarily mean that the guideline is going to be biased, but it is important to note that many of those involved in the production of guidelines do have potential conflicts of interest.
Where does one find clinical practice guidelines? There are many places where one can find them. They are often published in the medical literature, so one can search the PubMed system to find clinical practice guidelines. There's also a website from the Agency for Healthcare Research and Quality called the National Guidelines Clearinghouse. There are many professional associations that maintain clinical practice guidelines: the American College of Physicians, the American Heart Association and American College of Cardiology. There are government sites such as the U.S. Preventive Services Task Force, and even some healthcare delivery organizations and others who publish clinical practice guidelines on their sites.
Our approach to this lecture will be to provide the basic concepts of information retrieval and then look at 4 aspects of information retrieval. First, the content that is present in information retrieval systems. We'll then look at how that content is indexed, how it's retrieved, and we'll discuss the evaluation of retrieval systems. This slide provides an overview of the information retrieval process or system. The goal in information retrieval is to retrieve content, which may take the form of articles, book sections, web pages, images, videos, and so forth. In order for that content to be found, we need to index it, and we need to express that indexing in metadata, which is data that describes data, in this case, data that describes what's in the content. In order for users to find that content, they enter queries into a retrieval system using that metadata, and a search engine is the system or software that matches the queries to the content using the metadata. In that image on the previous slide, we see that there are 2 intellectual tasks of information retrieval. These are indexing and retrieval. Indexing, again, is the assigning of metadata to content items. We can assign metadata that reflects the subjects of what the content is about, and the subjects are described either as words or as phrases from controlled vocabularies, or there might be attributes that we index to facilitate retrieval, such as the name of the author, the source where the content comes from, its publication type, such as a randomized controlled trial or a systematic review. On the retrieval side, we use different approaches to retrieve content. Most content databases are quite large, so we need to use approaches that narrow our search results down and aim to get us to what we want. The most common approaches to retrieval are Boolean retrieval, where we use the Boolean operators and, or not, or increasingly information retrieval systems use natural language, and the search engine maps words that are common to the query that the user has typed in and the content that is available. Let's turn our attention more deeply into content, i.e. what is in information retrieval systems. And this classification system gives us a framework to think about the different types of content that are available. We'll look at bibliographic content, full text, annotated content, and aggregations that bring each of the 3 previous types of content together. Medline is the granddaddy of all bibliographic databases, not just in medicine, but really bibliographic databases in general. It was literally one of the first bibliographic databases to be available, and it has been available since the 1970s. Medline contains references to biomedical journal literature. So each Medline record has metadata about a specific article. The Medline database was really the original medical IR application, launched in 1971 with literature dating back to 1966, which is the beginning point of Medline, although now there's some older literature that's been added. And the access to Medline used to be commercial, but since 1997 it's been free essentially to the whole world via the PubMed system. Medline is produced by the National Library of Medicine, and it now has over 22 million references to peer-reviewed literature covering over 5,000 journals, mostly English language, a few non-English language journals, and about 750,000 new references are added yearly to Medline. And again, in the more modern era, Medline includes links to the full text of articles and other resources.
Let's talk about the category of annotated content. There may be non-textual types of content, such as images or gene sequences. Oftentimes, though, this content will be annotated with text or text in a structured kind of format. What do we mean by annotated content? What types of collections are there? Well, there are many image collections that are available. These usually come from the so-called visual medical specialties of dermatology, pathology, radiology. There are citation databases, so databases that have links between articles that cite each other in the bibliography. There are various evidence-based medicine databases, which are textual but also usually structured in a way that makes it easy to find and apply the evidence. There are databases or collections of clinical decision support rules. They may come from publishers, they may come from vendors. There are genomics databases, the growing number of databases of gene sequences, gene variants, genotype, phenotype associations, and so forth. These are available from the National Library of Medicine and others. And then there are various other miscellaneous databases, but important ones, things like clinicaltrials.gov, which is a database of all clinical trials that are currently or previously have been performed. An increasingly common type of content is aggregations, where many resources are integrated. We've seen major consolidation in the publishing industry, so now most of the major publishers have large collections of bundled content that they make available, various textbooks, subspecialty textbook journals, and so forth. There are also aggregations around biomedical research topics. For example, the myriad of linked databases from the National Center for Biotechnology Information, where there are gene sequences, which are linked to genes, which are linked to descriptions of gene variants, which are linked to descriptions of diseases caused by gene variants, and so forth. That can all be explored at the NCBI website. And there are also growing numbers of aggregations for consumers. Probably the best example is Medline Plus from the National Library of Medicine, that brings together many different types of information resources for consumers to learn more about health problems.
Now that we have discussed content, let's turn our attention to indexing. Again, remember that indexing is the assignment of metadata to content in order to facilitate retrieval. There are two major types of indexing used in information retrieval. One is human indexing with controlled vocabulary. The other is the automated indexing of all words. We may think of indexing as a human activity, but indexing can also be done by a computer, as is typically done by many search engines, where there is automated indexing of all the words that occur in each item of content. The most widely used controlled vocabulary for indexing in information retrieval systems is the medical subject headings, or MESH vocabulary. This is a vocabulary of over 26,000 terms that also has many synonyms for those terms. The MESH vocabulary is hierarchical. It's based on 16 trees, such as anatomy, diseases, chemicals, and drugs. The MESH vocabulary also has 83 subheadings that can be attached to a given MESH heading or term that will make it more specific. For example, for a disease, a subheading of diagnosis or therapy can be attached to indicate that the focus is more specific. For those who wish to explore the MESH vocabulary more, there's a MESH browser at the National Library of Medicine that allows one to explore the vocabulary. This slide shows a slice through the MESH vocabulary. So we're looking at the disease tree, and we see that there are many broad categories of diseases under the tree itself of diseases. One of these is cardiovascular diseases, which is in turn subdivided into cardiovascular abnormalities, heart diseases, vascular diseases. And then we see that vascular diseases is broken down into certain types of vascular disease, such as aneurysm, hypertension, vasculitis. So this is an example of the MESH vocabulary from the viewpoint of taking a slice through it down the disease tree. The other major type of indexing is automated indexing. This is a process that is done by a computer program and involves the indexing of all words that occur in the content items. So in bibliographic databases, the automated indexing process will include all the words in the title, abstracts, and sometimes other fields such as the author or subject headings. And in full text documents, the automated indexing process will essentially include everything, all of the text, the title, and so forth. The automated indexing process will often use a stop word list to remove common words that occur in almost all content items and are not very useful for searching, words like the, and which. Many systems also apply stemming, where words are stemmed to their root form. For example, from the standpoint of searching, the words coughs, coughing, and cough are probably not distinctive, and when we're searching on the concept of cough, we probably want to search on all of those expressions of that word. So the stemming process will remove the common suffixes like s and ing. Once indexing has been done, we can then move to the next key part of information retrieval, which is retrieval. And again, there are two general approaches to retrieval. One is Boolean retrieval, which is also called set-based retrieval or exact match retrieval. And then the other general approach is natural language retrieval, which is sometimes called automated retrieval or partial match retrieval. The two approaches are not mutually exclusive, and many systems either explicitly or implicitly can combine Boolean and natural language searching. Many of the early search systems tended to be Boolean, and Boolean searching is something that tends to be more preferred by experienced or power user types who want a lot of control over their searching. But as searching has become more widespread, particularly with the growth of the World Wide Web, we see that there has been a large amount of growth of natural language search systems. Let's review the Boolean operators and, or, and not. And or tend to be used much more heavily than not. And is the intersection. So when we use an and to combine two search terms, we'll retrieve only content items that have all of the terms. And is good, for example, when we want to take a specific disease and a treatment, we can narrow things down much more than just taking the disease itself or the treatment itself. Or is the union, and when we use or of different search terms, we'll retrieve content items that have any term. Or is often useful to handle synonyms or similar ways of expressing a concept, and we want to make sure that we retrieve all aspects of it. And not is when we use a search term to retrieve content that has one search term but not the other, kind of like a subtraction operator. The most widely used retrieval system for biomedical literature is PubMed from the National Library of Medicine. And PubMed is the NLM system that allows searching of the Medline database and other related databases. PubMed also includes, for example, some references from the old Medline database, which consists of bibliographic records from prior to 1966. And there are also other records in the PubMed system that are not indexed by the indexing process in Medline. PubMed is based on a Boolean heritage, but over the years it has incorporated a number of features of natural language searching. PubMed also does a lot of work behind the scenes. For example, it takes the user input and tries to map it to mesh terms. It also, if it can't map to mesh terms, will try to map to author names or other medical phrases. PubMed does have a Boolean set capability in its advanced searching interface, but this interface is almost essentially unnecessary at this point, as the screen interface can do just about everything that the Boolean set interface can do. When the results are displayed in PubMed, the default output order is reverse chronological, so the more recent articles are listed first, although this can also be changed to have the articles that most closely match the search terms rather than the reverse chronological order. Let's talk briefly about evaluation of retrieval systems. In the first year of the course, I did not cover this topic in the information retrieval lecture, but a board exam question showed up on this topic, so I've added it into the lecture. The evaluation of retrieval systems looks at how well these systems meet the needs of users, and there are many different types of research questions that can be asked, and this is an area where I have done some research over the years. We can ask, for example, is the retrieval system used? That's a measure of its value. Are the users satisfied? Do they find relevant information? And do they complete their desired task? There are many groups that have been studied with evaluation research of information retrieval. Probably the most studied group is physicians, and there actually have been some systematic reviews published in this area. Of the questions listed, the most common approach to evaluation is focused on do they retrieve relevant information. And that's an important question, but it may actually not capture the full spectrum of what we want to look at in evaluating retrieval systems. But the metrics of measuring the success of relevance did show up on the initial board exam. So let's define the metrics of recall and precision and give an example of their use. Recall is the number of documents or articles retrieved and deemed to be relevant divided by the total number of relevant articles, and this is actually equivalent to the diagnostic test measure of sensitivity, recall and sensitivity being equivalent. And precision is the number of retrieved and relevant documents divided by the number of retrieved documents in the search. There are some practical issues in how to measure relevant documents and what constitutes a retrieved documents, but it's important to know these formulas. So as an example, let's say we know there's 100 relevant documents out there in the database. A user does a search and retrieves 50 documents. Of those 50 documents retrieved, 25 are relevant to his or her information need. This gives us a recall of 25 retrieved and relevant divided by 100 known relevant, or 25%, and a precision of 25 retrieved and relevant divided by 50 retrieved documents, or 50%.
Let's carry out some interactive exercises in information retrieval. And you should listen to the questions here, then stop the lecture, answer the questions, and compare your answers with mine on the following slide. The questions are, what is the best approach to searching in the particular situations listed here? So for example, finding the best evidence for treatment of hypertension in elderly patients, Second, performing a systematic review of all studies of value of screening for prostate cancer. And then finally, finding an overview of congestive heart failure etiology, diagnostic methods, and treatment. What approaches would you take for these questions? Well, let's start with the first one, finding the best evidence for treatment of hypertension in the elderly. So this is a question of intervention or treatment, and we answer it with the best evidence, which is either a randomized controlled trial or a systematic review of randomized controlled trials. So we can use the various publication types, randomized controlled trial, systematic review, or meta-analysis. We can also use the clinical queries function of PubMed, which performs some of the publication type searching in the background for us. Second, performing a systematic review of all studies of value of screening for prostate cancer. So when we assess screening, remember that screening is an intervention, even though it's done using a diagnostic test, but the screening process itself is an intervention because we're trying to reduce the mortality or complications, for example, of prostate cancer. So we use the publication type randomized controlled trial to find all those trials that we will use in a systematic review that we're carrying out. Finally, finding an overview of congestive heart failure, etiology, diagnostic methods, and treatment. We might look for a classical review article in the literature, or we may consult a textbook type of resource that gives us an overview of congestive heart failure. Here are some additional suggested readings in the areas of evidence-based practice and information retrieval. There is a chapter on evidence-based medicine and clinical practice guidelines in the textbook by Hoyt and Yoshihashi. There's also a chapter on information retrieval in the textbook by Shortliff and Semino. I'm involved in the authoring of both of those chapters. For even more detailed information, we already discussed the Guyot et al. User's Guides to the Medical Literature, as well as the textbook on information retrieval that I have written.